So, good evening, doctors. A very warm welcome to all of you to the CME webinar session by Kerala Ayurveda Limited in association with Parampara. First of all, I would like to thank Parampara organization to hold our hands for a wonderful session with our dearest Asmabi ma'am. And this Parampara is an organization in Punjab where doctors are joined together to share the experience to the young doctors and also to support and guide young Ayurvedic doctors. And Kerala Ayurveda Limited is an organization from Kerala. And today we have the topic clinical insights into female infertility and Ayurvedic approach. And for that, we have an eminent speaker, Dr. M.A. Asmabi. Regarding the speaker, I would like to introduce a few words. And currently, ma'am is working as a medical officer under ISM department, Government of Kerala. And ma'am has completed BMS and MS in Prasudi Tantra and Sri Roga from Government Ayurveda College, Trivandrum, which is one of the prestigious institutions all over the world, and has 15 years experience in gynecology and infertility treatments, and has taken several seminars and national and international levels, and also taking more and more public awareness classes also, and has a recipient of AMI, Ayurveda Medical Association of India, a Legend Pharmaceutical Bishop Pratibha Award, and also has different publications including online and offline platforms, and also articles published in JAM and PubMed Indexed Journal and Ayurveda Journal of Case Report of AAA, and also has published in Ayurvedian of Kottakkal Ayurveda Shala. And with all the respect, on behalf of Kerala Ayurveda and Parampara, I'm inviting Dr. M. Asmabi ma'am to the session. Welcome, ma'am. Welcome to the session. And we have the mentor of the Parampara, the well-known Dr. Amarpal Singh Shergill sir, who is the recipient of State Dhanvantari Award from Punjab, and also former Ayurvedic medical officer and at Government of Punjab. Welcome, sir. Welcome to the session. And we have other doctors, Dr. Jasmeet and Dr. Anit Garg, who was always on discussion with me regarding the session, how to conduct the session and all those things. Thank you for your support and welcome to the session, doctors. And I would like to invite one of our colleague, Mr. Sachin Tiwari, who is the marketing manager at Punjab area. Welcome, Mr. Sachin. And my team technical support, Mr. Sumesh is also here. Welcome, Sumesh. And before going to the session, I would like to give a brief regarding Kerala Ayurveda Limited. Kerala Ayurveda Limited is a Ayurveda pharmaceutical company from Kerala and established in 1945 by the Vaidyan KGK Panikar. And in 1948, we have started a small-scale manufacturing unit called Marunupura at Aluva. And we have expanded our branches. And in 1975, it is incorporated as Kerala Pharmacy Private Limited. And also, we won the state award for the productivity and recognized as the Center for Excellence in R&D by Department of Science and Technology. And in 1994, we pioneered the patent and proprietary medicines in the Kerala's Ayurveda ethical segment. And also in 2001, we received the GMP certification for our factory. And we have the 8 years of Ayurveda legacy. And also, we have a portfolio of 300 classical and 100 plus patented innovations. And also, we are the trial basis in Ayurveda as a pioneer of proprietary medicines among Kerala-based companies. And also, we launched the Gridam capsules in the Ayurveda segment initially. And that's all about our firm. And I'm not taking much more time. We are all eagerly waiting for the session. And over to Amarpal Singh, sir, for the introduction. Welcome, sir. Thank you.
Thank you. Thank you, Dr. Rahul. Dear doctors, welcome you all on the platform of Parampara. As you know, Parampara is an organization which is holding seminars, workshop, camps, and CMEs in relative to Ayurveda. So Parampara is contributing a lot in the state of Punjab. and Parampara is continuing its Parampara. Today we are having webinar on the female infertility in collaboration with the Kerala Ayurveda. Our speaker today is an eminent Ayurvedic personality, Dr. M.A. Asma B. As her introduction has already been given by a doctor, so nothing more to say. So straightforward, we are going to start the session. And thanks to Dr. Asma B for her kindness that she has accepted our invitation. Thank you very much. Okay, sir, we can continue.
Thank you, sir. Ma'am, you can proceed. Thank you for once again thanking you from on the behalf of Kerala Ayurveda. You can have the session. Thank you.
Very good evening, all of you. Namaste. Thank you all for the invitation, for all the organizers for this invitation of this program, especially Kerala Ayurveda Parampara team, and also Dr. Rahul, Dr. Amritpal Singh sir, all the organizers who present here. And today, the topic given me is a very vast and large topic. That's the female infertility. So I would like to share some clinical experiences regarding the female infertility, especially among the Kerala practices. And I would like to share some views and also some merits and demerits of this regarding our practices. And here, first of all, I would like to say that it's a large topic and only some parts we have to cover during this presentation itself. So let me start. I hope it is clear and my voice is also audible.
Yes, ma'am.
Yeah, it's okay. So regarding Vanditva or infertility, it's among our definition, it's the unable to conceive a baby even after the 1 year of unprotected coitus. But actually, in our concern, failure to deliver a viable child rather than failure to conceive. Even though after conception is not enough, but instead of that, to get a good and a healthy progeny. Viryavandam Sudam Sude. Through all healthy manner, we have to get it. So the safety assurance of the obstetrical outcome, which depends upon, there is the proper intranatal care, proper antenatal care, preconception care, healthy lifestyle, especially in the reproductive age group. So we have to start the preparation of a baby from through physically and also from psychologically from the reproductive period itself. So coming to the infertility evaluation, we can see that male, female, how much percentage itself around 30 to 40% male, 40 to 55% female, and 10% combined and 10% unexplained. So as per we know that as a clinicians, in our OPD, some patients are to be coming with the lady patients are to be coming with their parents or from their any of their friends for the infertility evaluation or infertility treatment. Of course, we have to counseling them at the first sitting itself. Both the male and female factors are equally responsible for the fertility, and we should have to consider both the factors parallelly. But here the topic is regarding the female infertility, so that we have to be established this thing more here. But even though, as per Charagacharya, from one quotation itself, it's beautifully mentioned that all the etiological factors of anapatyata or infertility. Here, Yoni Pradoshat Manaso Abhidhavat, Shukla Asrak Ahara Vihara Doshat, Akala Yoga Balasamkshayacha, Garbam Chirat Vindadi Saprajabi. That means Yoni Pradoshat, all abnormalities of the female reproductive system, Manaso Abhidhabat, any psychological impairment among couple, Shukla Asrak Dosha, defective sperm and ovum, Ahara Vihara Doshat, abnormal dietetics and lifestyle, then Akala Yoga, improper time of coitus, and Bala Samshayat, any physical illness. All these things may be lead to delayed conception or otherwise related to infertility. So what are the factors essential for conception? Here we know that Shuddhe Garbhashaye Marge Rekte Shukle Anile Hridi. Here itself in some concise manner is that Ridu Kshetra Ambu Bijana. Here the Ridu should be correct, Kshetra should be corrected, Ambu and Bija. So all these factors like uterine, endometrial, vulvovaginal, and all these factors should be correct. Then alone the fertility should be achieved. So that if a patient start to be coming to us, so what are the, we are mainly focusing on the modern investigation procedures and investigations. Of course, we know that the patients start to be coming with to our OPD with a large number of documents and files which they have previously undergone their treatment and all. So when we are writing any further investigations, we should have relevant to the case or clinical features. It should be simple, least invasive, and most productive one. Maximum efficiency should be targeted and step-by-step approach to right diagnosis. So for that, in infertility, one important thing is the male factor. In case of male factor, do semen analysis at first. It's very cost-effective investigation, we know, but most of them are females are doing all type of investigations, including AMH, laparoscopy, everything may be there. Even though after 3 or 4 years of married life, they didn't check any semen report. In some cases, it may be like that, but we should have to do the least effective, means cost-effective and most effective investigation, that is the semen analysis. We should have to go through the count, motility, morphology, liquefaction time, and everything, every factors should be monitored regarding the male factor. Then coming to female factor, there is ovarian factor, tubal factor, uterine factors, and cervical factors. So that for investigation in regarding the ovarian factor, we should have to do FSH and LH on day 2 of the second day of the cycle. If we are checking progesterone, day 21st of the cycle, and TSH and prolactin any time of the cycle, irrespective of the day of cycle, we can do thyroid, TSH and prolactin. Then in normal values, we know that FSH should be greater than LH, but both FSH and LH should be less than 10. That is the normal value. But in cases, if LH is more than FSH, then it's an indication of PCOD. If FSH is more than 10 or more high values, then that is an impaired ovarian function, like that premature ovarian failure or decreased ovarian reserve. In such cases, FSH may be increased. In that cases, next investigation is the AMH, anti-Mullerian hormone. Then if FSH is more than 25, there may be menopausal value. Okay, is it clear? So we have to do the investigation FSH and LH on day 2 of the cycle. Normal value, FSH should be more than LH and both should be less than 10. If LH is increased more than that of FSH in case of PCOS, if FSH is more than 10, impaired follicle development may be delayed. If FSH is more than 25, that means menopausal level. Okay. Then we have to do day 21st progesterone to check. Some cases of infertility means early periods are to be coming like luteal phase defect. I will explain in coming slides. Luteinized or there may be the corpus luteal insufficiency. In such cases, maybe an ovulation or even though after ovulation, the hormone value, progesterone value may be get decreased. Okay, then coming to TSH and prolactin, anytime, irrespective of the day of cycle, we can do the investigations. So these are the ovarian factors of infertility. We have to do the investigations. Then tubal factor. Tubal factor, we know that HSG, usually hysterosonography or through laparoscopy, we can know is both the fallopian tube is patent or not, is there any block or is there any problems we can assess. Then uterine factors. For uterine factors, major things we can analyze or investigate through the USG, ultrasonography itself. So uterine fibroids, ovarian cyst or endometrial thickness and any uterine findings we can investigate through the ultrasonography. But in some cases like adenomyosis, endometriosis, in such cases, the golden standard is the laparoscopy itself. Okay. Then coming to cervical. cervical or vaginal factors of infertility, here we have to do the per speculum, and per vaginal examination is very, very important. While we are doing the per speculum examination, we can see some cervicitis or any abnormal discharges or abnormal infection that may also cause some maybe reason to vaginal causes of infertility, and some post-coital testes also we can analyze this type of conditions. Then hormonal assays, prolactin, TSH, FSH and LH, estrogen, progesterone, androgens and AMH. Normal values according to lab value we know. Here we will discuss in later. So, yoni pradoshad. So, coming to the one important factor, that is we explained the delayed conception or anapatya may be due to yoni pradoshad. Yoni pradosha means all the 20 or vimshati yoni rogas will come here, or all the problems of the female reproductive tract will come here, and all etiological factors which starting from ovulatory dysfunction, tubal disorders, uterine factors, cervical factors, and pelvic endometriosis. So out of that, ovarian factors, if we are discussing here, decreased ovarian reserve or AMH value may be decreased under decreased follicular development. Then luteinized unruptured follicle. The follicle may develop, but the follicle is not rupturing. That is termed as the luteinized unruptured follicle. And luteal phase defect. Here, due to the support of the progesterone is decreased and the corpus luteal insufficiency, that may also lead for the factor for infertility. And anovulation. Anovulation, there are so many reasons for anovulation, like we know that increased prolactin level or different type of secondary amenorrhea. Out of that, PCOS, polycystic ovarian syndrome, is one of the most important reason, especially due to some lifestyle disorders and lifestyle changes we are getting. Anovulation and PCOD is the one of the most important causes of infertility among ovarian factors. So just I'm starting some case discussion regarding these things, and out of that PCOS will come later because it's a large topic and elaborate one. Of that, first one is the decreased ovarian reserve. Decreased ovarian reserve, that means for an optimal fertility, the value of AMH should be 4 to 6. For satisfactory fertility, 2.2 to 4. Low fertility, it will be 0.3 to 2.2. Very low level, 0 to 0.3. And one another thing is, interesting thing is noticed, if the AMH value is more than 6.8, that is an indication of PCOS. So that in PCOS, AMH value may be increased. That is also causes some defective sperm or defective ovum ovulation or ovum formation. And low level, very low level of AMH, it is also causes some problem to the conception. And in cases of decreased ovarian reserve, we are checking the AFC, that is the antral follicular count. If the antral follicular count 2 to 10 millimeter count is measured on day 2 to 2nd or 3rd day of the cycle, it is doing under the transvaginal TVS sonography. The reference range 5 to 8 antral follicle per ovary is the normal reserve. If less than 3, that is the poor reserve, and more follicles in cases of PCOS also. So what is the clinical presentation? If a patient is coming with decreased ovarian reserve, we can see that they have regular cycles. We will not notice, actually, when they are coming to as an infertility patients, then alone we will check the AMH value, because otherwise their cycles are regular, then ovulation may also forming regular, and everything may be regular. But if we are for an assessing point of the investigation points of fertility, we are noticed that the AMH value, anti-Mullerian hormone, may be reduced, and in such cases AFC or antral follicular count is also found decreased. Okay, then to an extent the FSH may be changes. The FSH may be started to increase, but if a higher value, then it's an ending to a premature ovarian failure or premature menopause. But in normal decreased DOR cases, it is not happening. Less estrogen may be there. And while they are presenting their symptoms or regarding the intercourse and regarding their sexual intercourse, we observed or noticed that there is a decreased estrogenic stage and decreased lubrication. That is vaginal lubrication during the sexual intercourse is to be found very much decreased in such cases. There is a vaginal dryness. It may be due to the decreased estrogen value. As per the modern treatment, they are giving some good lifestyle modifications, taking vitamins. Vitamins is also having a good role. I found that if the patient is having decreased ovarian reserve or reduced AMH value, the vitamin D is also found to be decreased. Usually we know that even though after as a post-COVID condition, all of them have reduced vitamin D or insufficient vitamin D. Here also it is to be the same observation received. Then correct exercise or exercise regularly. Then other methods, they are advising that using donated embryo or donated egg. If the AMH value is to be decreased, then usually they advise to take another or donor ovum from a third person and to do the ICSI or IVS procedures. So this is the main current conditions of the AMH decreased AMH or decreased ovarian reserve. So here, what's our output? What we can do? Or through Ayurveda, what's the treatment approaches? Here, first important thing is that after getting the proper Agni Dipti or Agni Dibana to the patient, then coming to Brahmana and Dhatu Pushti. This is the line of treatment we have to adopt. In some cases, in lab value, AMH may increases. It's not mandatory, but the quality of the ovum, surely it will increase and conception will occur, surely. So the treatment protocol we have to do first mild rukshana if needed. So according to Agni Dipti of the patient, according to BMI of the patient, we can do how to do the rukshana. Is it needed in the form of Udvartana, like powder massage, or otherwise, if needed, internal medicines like Vaishwanara Churna and Takra for getting proper Agni Dipti and rukshana. So according to the patient BMI and patient's condition, patient's acne, we can decide how much day it's needed to do rukshana. It's for 3 days, 5 days, 7 days, or according to patient condition, we can select that. Then next is the snehana. Snehana is the important thing to getting Dhatu Pushti here. So that especially medicines like Sukumara Grida, Dadimadi Grida or Phalasarpi are the choices of medicine to do Snehabana or Snehana. Atsa Snehabana itself is a good method here. So after during the Snehabana, according to the, whenever they get the Sammik Lakshana, up to that extent we have to continue Snehana. Then after Snehana, mild Mridu Anulomana should be conducted here because we know that Pitta may be reduced here. So after doing it's a mild purgation or Mridu Anulomana is only needed to getting more Pitta should not be subsided here. Then after Snehana, after mild or Mridu Anulomana, leave the patient with internal medicines, and on coming cycles, around the ovulatory to pre-ovulatory time, Rajayapana Basti or Chiravasti. Chiravasti and Rajayapana Basti, all these are having some Dhatu Pushtigara Vastis. And Uttaravasti. Uttaravasti is also for getting the local administration of the medicines. If possible, we can do, if there is no infection, surely we can do intrauterine procedure as Uttaravasti. And this Rajayapana or Chirabasti and Uttarabasti can be performed on the next cycle. So first cycle, after Agni Dipti, Rukshana, Snehana and Mridu Anulomana, leave the patient with internal medicines, and coming cycle, just after, during the pre-ovulatory to ovulatory time, we have to do Basti. And if possible, Shirodhara and Nasya, I have a good result here because we know that in such conditions, the FSH value is a tendency to increases, and this HPO axis, this formation of, and to get a proper stimulation of the HPO axis and the proper formation of the LH and FSH, the Shirodhara and Nasya have a good result, I think. So that Shirodhara, it is, if it is in the form of Takradhara or otherwise the Shmudak Shiradhara are the choices, and Nasya here also we can to administer to different type of medicines. Then here having the Sukumara Grida, here Punarnava, Dashmula, Erendamula, Ashwagandha, Eshti, Madhu are the means the ingredients of the drug. It's indicated in Vriddhi, Vidradi, Vadaroga, Shobha, Mudhavada, etc. The practical means the therapeutic indications. But coming to the practical indications, dysmenorrhea, amenorrhea, PCOS, low AMH value, infertility, to get the good endometrial thickness, and have a role in the case of estrogenic effect. And coming to other drug of choice is the phalasarpi. Here the ingredients are the manjishta, kushta, tagara, and also different drugs like vajikanda, shadavari. Therapeutic indications are the vatapitta shamana, brahmana, garbha pushti, yoni dosha, shukla, garbha dosha, bija dushti, etc. The therapeutic indications. And in practical indications, repeated pregnancy loss. Here the pushpe pidam phalaya that briyamana prajadanam tada hidehi. That means it is an indications where there is repeated pregnancy loss or habitual abortion. We can use the phalasarpi, and after ovulation to get the implantation, it will be have a good as a drug of choice. And for the implantation, here also to get the endometrium correct and have a progesteronic action. Then next is the Dadimadi Gridam. Here, Dadima, Dhanyaka, Chitraga, Shinkivera, Nagara, etc. The ingredients of the drug. Here, Mudha Vadanulomanam, Tukka Prasavininamcha, Vantyanamcha Prashaside. Here, the Shasa, Kasa, Pandu, Gulma, etc. Practical indications are the chronic gastritis, anemia, uterine factors, and infertility. So, these are the some choices of drugs, not enough. Here, some other drugs like Datriya, Digrida, is also good to patients who are having low AMH value. So this is the Snehana, drug of choice was Snehana or Snehapana. So after Snehapana, Mridu Anulomana, instead of Videjana, Mridu Anulomana, we can do by Erenda Kaila, Sukumara Erenda or Gandharva Erenda mixed with Shira can be given. And if the patient is having, in some cases, they may have increased burning sensation or pitta dushti or pitta means pitta vriddhi lakshanas may be there. In such cases, we can select Vipatti Churna also for Mridu Videjana. Then Vasti, I mentioned that Anuvasana Vasti, Niruha Vasti or Uttara Vasti. In cases of Anuvasana Vasti, Alpa Pushpa, Nashta Pushpa, Nashta Bija. It's for oligomenorrhea, amenorrhea, and anovulation. Anuvasana Vasti is found to be good. And the Niruha Vasti, out of the Niruha Vasti, Kshiravasti and Rajayapana Vasti for Kshiravasti, Eshtimadu Kshidapaga, Guduchi Kalka, Mahanarayan Taila, Tiktagagrudha, etc. are the medicines which have a choice of pitta predominant conditions, and we can select as the Kshiravasti ingredients. And Rajayapana Vasti, actually Rajayapana Vasti, some practical indications like hypoplastic uterus, if the uterus is to be reduced in size, and repeated pregnancy loss, premature ovarian failure, and in male cases like azoospermia, severe oligospermia are the choices. And Rajayapana Vasti is the indication from Mustadi Rajayapana Vasti in Charaka Siddhisthana. Here we can see that so many drugs like Kalkadravya, other medicines, and also there is added some goat's soup for the Brahmana, like that. So many ingredients. Anjana is to be added as a Kalka. So that so many drugs are to be means included as the Kashaya Dravya, Kalka Dravya, and the cow's milk, cow's ghee, meat soup, so many drugs which are helping for the Darba Pushtis to be added in Rajayapana Vasti. The reference from Mustadi Rajayapana Vasti, Charaka Samhita Siddhisthana. So it's also found effective in these cases of decreased ovarian reserve or like repeated pregnancy loss and all. Then coming to Uttara Vasti, so due to the time limit, I'm not going to the procedure in detail, but it's a unique procedure for gynecological disorders. It's a sudden effect, especially on the target organs. And also for selection of the medicine like in the form of vaginal douche or vaginal Uttarabasti, intrauterine Uttarabasti, urethral Uttarabasti may be advised in different classical aspect. But here we are doing in the form of Piju or intrauterine or intravaginal Uttarabasti. choices of medicine here, Mahanarayan Taila, Sukumara Grida or Phalasarpi. On the first day, if you are doing Uttarabasti, it's better to do by adding one pinch of Kalyana Kshara to get the stimulation of the tract. And after that, Taila alone or mixed with ghee, we can use for the means Uttarabasti. Okay, so this is the major procedures we are doing, like Rukshana. During the Rukshana time itself, if needed, we can do Takradhara or Shirodhara. Uddartana if needed according to the patient's BMI and all. So first Rukshana, then second is the Snehana, then Mridu Anulomana. After Mridu Anulomana, on the next cycle, Rajayapanabasti and Uttarabasti or Kshirabasti and Uttarabasti. Then possible Shirodhara and Nasya. So these are the treatment needed for the law. Actually, when we are thinking about, in some rare cases, without taking this Panchakarma therapy, only with internal medicines itself, we will get a good follicle and they will conceive. But actually, our acharyas are mentioned as preconceptionally itself for getting Viryavantam Sudam Sude, for getting good and healthy progeny, as a without infertility patients, means irrespective if they are coming for infertility, for getting a preconceptional preparation itself, this Panchakarma is to be advised. If it is not possible, if the patient especially having decreased ovarian reserve, low AMH cases, in modern methodology like this IVF and ICSI procedures, artificial reproductive techniques, they will tell that if AMH value is reduced or decreased follicular development, surely you have to go for the donor ovum and like that. So in that place, we are doing all this Panchakarma to get a good follicle from their own follicle and for their own baby. So one case here, the age of the patient 32, married life 8 years. She's working as a nursing staff at one hospital, modern hospital. Her AMH value 0.09. Actually, in that patient, they advised the same thing to take a donor ovum and do the ICSI procedure. But actually, they are not willing to do such a procedure. And if they are getting a baby from their own, if it is okay, otherwise they are ready to adopt a baby. Not taking the donor ovum is not ready in that patient, so that they came for the Ayurvedic management. The on first time for getting the Rukshana and Agni Diti, Chirivilodi Kashaya mixed with the Tippali Churna was given internally. Kumaryasava and Bringarajasava was given. Then after 1 month of this internal medicines, just I started Snehapana with the Sukumara Krida. And after Snehana, the same procedure, Murdu Anudomana was given. And in that patient, Rajayapanavasti and Uttaravasti was done. Actually, after 3 to 4 months of the internal medicines and also therapy, she got a good conception and a healthy baby. Now, surprisingly, is that after getting her first baby, now without much any intervention, she again conceived and she got her second baby now. That was I think that after getting a stimulation of the ovary and also getting follicle, as a good follicle is obtained and the first baby is also they received. After without any gap itself, that they didn't expect, because after 8 years of married life, they didn't get a baby. They a different type of treatment. So they actually they didn't expect they will get again baby on the during. So that's why itself they didn't take any precautions, and the baby is having coming to 1.5 years. Again she conceived and now she delivered her second baby. Then another case, age of the patient 26, married life 5 years. Here the AMH value 1. So in previous case, I was given Chirivilluadi Kashaya and the Tippali Churna because in that patient Agni Dipti is very low. And for getting the proper Agni Dipti and Anulomana, I was started the Chirivilluadi and the Tippali Churna. But here this patient, she's having some Pitta Dushti is there. So Drakshadi Kashaya, but Agni was proper. Drakshadi Kashaya was started internally and in small quantities of Datriyadi Gruda was given. So, as a form of Brahmana Snehabana, Tatriyadi Gruda was continued. And here, Chiravasti and Uttravasti was also performed. Actually, that patient conceived, but within 1 week itself, that was missed. And again, she continued the internal medicines. And that was ended with a twin pregnancy. Babies are to be baby girls are to be received to that patient. Actually, here we can see that the reduced AMH here also after getting stimulated by our medicines, and if the Dadu is to be occurred, if the follicles are ready to get ovulated, then there may be chances even for the say single pregnancy, or in rare cases it may end with the twin pregnancy. Then so this is one case, that means one thing, that is the decreased ovarian reserve or reduced AMH value. But simultaneously we have to differentiate diagnosis how this DOR and POF, premature ovarian failure, can be means understand or differentiate. So the main difference is that in cases of POF, that is premature menopause or premature ovarian failure, FSH value is to be found elevated. On scan report in the previous year, if we are checked one scan report, and on coming year or now presently, if we are doing scan, then the volume of ovary is found to be decreases. Then amenorrhea, there may be sudden amenorrhea. We noticed that say correct means the cycles are to be coming normal and normal. Then as on a sudden the periods are to be stopped, and there is no say period of amenorrhea may be there. Okay, so in one patient, some always we are telling that success stories, especially we are discussing about case reports, and we are very interested to tell about the success stories. But now I am presenting a failed story, because every time we know that from the failure, we have to learn some things or some lessons. Here, a 26-year patient, she coming with secondary infertility. Actually, this secondary infertility and secondary amenorrhea, with much confidence, I told that, oh, it's only 26 years. She's having secondary infertility. One child is there, and she's having secondary amenorrhea. Surely, I will do some such and such treatment, some panchakarma. Surely, you will get a baby. That with confidently, I told. Because without going for the much more investigations and to getting a proper diagnosis, such a comment I done. But even though after just I started the treatment, like Rukshana, Snehana, even Vamana, Virechna, Vasti, everything. Actually, after that, because I didn't expect on this 26 years and she's having one child, I didn't never expect she's having a case of premature menopause. Actually, after the treatment procedures, I just again once checked her FSH value. I surprised that her FSH value on the age of 26 years, it is to be very, very high value. And never that will not respond after any treatment, that didn't respond, and the secondary amenorrhea persist. So from that failure, I learned a lesson, and whenever the patient came to with the secondary amenorrhea, especially if they are presenting with any type of vaginal dryness or some body heat or some sort of this hot flushes, some changes of manifestations of these hot flushes, surely we have to do, or you should have to investigate FSH value. Second one, if the volume of ovary, if it is decreased than that of the previous value, then again we have to do this AMH value. Okay, from these findings, we can diagnose the case and differentiate the case. Is it a premature ovarian failure or premature menopause? In rare conditions, this POF may respond. I will explain such a case coming. But we should have to differentiate diagnosis in between PCO, in between decreased ovarian reserve and premature ovarian failure or premature menopause. Otherwise, we will have some false determinations. So another case here, the decreased ovarian reserve or premature ovarian failure. In decreased ovarian reserve, menstrual history may be, or it may be in normal or regular cycle. FSH may be slightly increased, but not much to the menopausal value. But in case of POF, hot flashes may be there, some menopausal symptoms may be there, and vaginal dryness may be very much found in that, observed in that patients. And one another thing is the PCOS or polycystic ovarian syndrome. Here may be the secondary amenorrhea. that also you should have to differential, coming to the differential diagnosis. Okay. Then another case of another success story of the premature ovarian failure. Here only the age of the patient 24 years. Here actually the diagnosed case of POF. Her gynecologist diagnosed it as premature ovarian failure on the age of 24. There is no chance to get proper menstruation, no chance to get a conception. But according to her history, the menarche at 14 years, all the secondary sexual characters are okay. On 2021, up to January, all the cycles were regular. On March, it was induced. On May, it was again induced. There is only some induced cycles in between 6 months. That's around 6 months of amenorrhea. Among that, 2 cycles were induced. So when she came to OP, just I started some internal medicines like Tila, Shatapushpa, and Vyosha. To take internally by mixed with some jaggery and also some ghee like Sukumara Grida mixed with Pistila and Shadapupa was started internally. And some Tikshna drugs also to be added to that patient. Here her AMH value is found that 0.21. Here we can see that her AMH value, anti-Mullerian hormone, it's very, very, very low, is only 0.21. And her FSH value is to be found increased value. And here the case coming to us 6 months of amenorrhea. But actually among the 6 months of amenorrhea, 2 induced cycles received. On her this previous report, we can see that this both ovaries shows reduced size. That's the right ovary 1.3 into 1 centimeter and left ovary only 1.5 into 1.1 centimeter. The volume of ovary is found to be decreased and FSH value found to be increased. So these are the findings in that patient. And as per Ayurveda, the case is diagnosed as the Dhatu Kshayaja Vandya. Her Vata Vriddhi and Pitta Kabakshaya was not tested. So internal medicines like, as I mentioned earlier, Shatapushpa Churna, Tila are to be added internally. And some asavas like Kumari Asava and Bringaraj Asava. Actually, Kumari Asava have a property to get a good endometrium and all. Then Bringaraj Asava actually mentioned in the Shayaja Kasa. We can from Falashruti or Prakarana of the Shaya Kasa. So here we can consider as a Daduk Shayaja. So to get improved for the Daduk Shayaja, just I'm taking this Bringaraj Asava to this context. Then after some internal medicines, the procedures alternated like Shirodhara, Snehana, Rajyapanavasti, and Uttravasti. All this protocol continued. The treatment, it take about 4 to 5 months. Preparation of some Rukshana. She's having a lean patient, not much obese. So the Rukshana are taken for 3 days. She's having good acne also. Then Snehana, Samik Snigdha Lakshana is obtained after 6 days of Snehapana. Mild laxation or Mrudu Anulomana is carried out 1 day. And leave that patient with internal medicines. Or actually, after starting this treatment and procedures, internal medicines itself, she started to menstruation without inducing any progesterone tablet. Her menstruation is to be coming as a normal. And then Rajyapanavasti and Uttravasti carried out. So after that, Shirodhara is also done to that patient. Actually, Dhara is having, I mentioned, to HPO axis and also to correction of the FSH. Takradhara or Dashamula Kshiradhara is a good result. And then the before treatment FSH value was 18 and after treatment it was reduced to 0.5. And AMH value, it was 0.2, 0.2, and then it was increased to 0.4. Here, with an LMP of 4 to 2022, very surprisingly, it was found that she didn't attain her menstruation. Actually, after started the internal medicines and treatment, her cycles are started to come, and after a long period of after a period of amenorrhea, we checked her beta HCG value and her urine means pregnancy test. It was found positive, and her beta HCG value that was very high. And on 2022, means 2022, she delivered a healthy baby weighing 3.7 kg. This case report is published in Ayurveda Management Protocol for Female Infertility due to Premature Ovarian Failure, a case report in Ayurveda AIA, Ayurveda means Journal of Case Reports by All India Institute of Ayurveda. Actually, it's a rare case, it's a rare presentation. But out of our clinical practice, the prognosis actually is very, very bad regarding this premature menopause, premature ovarian failure. These are the treatment protocol we have to accept. But again and again, if the patients have to be coming with in a younger age, here the age factor is only 24. But in that age, she was diagnosed with POF, her FSH was high, and her volume of ovaries decreased. But as of a sudden, within few months itself, she came for Ayurvedic treatment. I think that may be benefited in that case. But in all cases, we can't tell that this prognosis, but we can try in all the cases of premature ovarian failure or otherwise in decreased. One another advantage is that we can try in cases of reduced AMH value or decreased ovarian failure, decreased ovarian reserve. In such cases, we can accept the same protocol. That is one advantage I received from that case itself. Okay. Then another case, she is having a modern doctor. She is working, and her AMH value is found at 0.10. Actually, this is also very low comparing to the previous case, but she's having regular cycles. So not FSH value is not much high. She is not attained premature menopause, but her value of AMH is very, very low. And so I added some medicines to get her Hinguvajadi, some medicines like to get her Aknadipti at first. And she's having very very stressed out. Then I added some tablets like Manomitram and Ashwagandha Churna was added to that patient. And after that, I given some medicines like Kalyana Girda for Snehapana and Mridu Anulomana was done. Actually, in that case, all this Rajayabnavasti or other Dhara, that treatment, this Panchakarma treatment actually is not performed. Some internal medicines are only started, but surprisingly, I found that by taking this in between that internal medicines, that patient got conceived. Now she is on second trimester and she is continuing her pregnancy uneventfully. So this is regarding some cases of ovarian factors. Out of the ovarian factors, decreased ovarian reserve and premature ovarian failure due to the lifestyle changes, parallel to the PCOS. We are observing so many cases due to the vitamins insufficiency and also this reduced AMH cases. Through such type of Panchakarma treatment, we can do improvement of the quality of follicle. Then another condition is the luteal phase defect. Here, the ovulation is everything okay, but normal, we know that the normal lifespan of the corpus luteum is about 14 days. Okay, after ovulation or the corpus luteum, it will be 14 days. But actually, in luteal phase defect or corpus luteal insufficiency, that day will be, the progesterone phase will be get decreased. It will be 10 days or 9 days. The periods will, we are expecting that she will conceive and there is a good follicle, good endometrium, everything is okay. We will, means intercourse is okay, semen parameters, everything okay. We are expecting that there is a good conception will occur. But actually, before the date of menstruation, they will came, before LMP, they will came with their menstrual cycle. Here we have to investigate progesterone value on day 21 of the cycle. What's happening here? Mainly the implantation failure is happening. Here hinder the implantation. The causes of implantation failure may be induced ovulation, elevated prolactin, hypothyroidism, improper follicular genesis, and some cases like dysfunctional uterine bleeding. Here, as per Ayurveda, we can consider it as asraja. Asraja Yoni Vyabat, which is described as the Rekta Pittagarer Narya, Rektam Pittena Dushidam, Labda Garbe Vabi Asrija. That means here the ovulation may happening, sometimes fertilization may happening, but implantation is not become proper due to the Rekta Pittagara. Means increased Rekta and increased Pitta predominance on the uterus, and endometrium is not receptive during that time. And endometrium is always, I will tell to our fertility patient is that especially after ovulation, you should have to keep all the means avoid almost all the spicy food, and your mind and body, everything should be cool to recept that fertilized ovum or fertilized embryo towards the uterus. And actually the implantation will occur after 6th day of ovulation. Just after ovulation, the fertilization will happen within the fallopian tube, and from the fallopian tube it will be turned towards the uterus, and the the implantation will start on the 6th day after ovulation. And during that time itself, some patients will tell that some pain or some feeling on the lower abdomen and some cramps may be happening. Here maybe the endometrium is not much receptive, and here the treatment or the management principle will be Pitta Shamana, Rekta Prasadana, like medicines like there are so many choices of medicines we have, like Tiktaga, Gudujadi, Drakshadi, Chirabala, and some treatment like Shirodhara, Tala, Snehana, Virejana, Chirapasti are the choices of treatment. And for implantation, after ovulation, we have to give small quantities of Phalasarpi, Shadavari Adigrada, Dadimadigrada, Lakshmana Mulak Chirapaga, Peral Mutta. Peral Mutta is the drug, like I will explain on the next slide. Small quantities of Pushyanuk Churna, Shirabala 101 Avarti mixed with milk are the medicines, all the medicines, because we know that after during the secretory phase, there may be Pitta predominant. So the medicine, the choices of medicine will be Pitta Shamana, and especially they have Garbhasthavana. Okay. This Ficus bengalensis link is the drug is the peral motor. So the means the bud of that means plant that can be used mixed with milk, or otherwise can be mixed with not buttermilk, butter mixed with butter, honey or milk we can use for the Garbhasthabana. And here the botanical name is the Ficus bengalensis link. The plant name in different Sanskrit Vata, English banyan tree, and Malayalam, in Malayalam it is the peral. And another drug is the Lakshmana. Lakshmana, we know it's having Ipomea drug is a group of drug. It's in Putrol Padanam, and also for the actually in it will be better for the Garbhasthabana itself. Then coming to a cases of luteal phase defect, as a case of primary infertility, married life 5 years, her age is 26 years, her cycles was 19 to 21 days. Actually, ovulation is, we can observe on USG, or from her symptoms itself, the ovulation feel on the 13th or 14th day. But actually, after not getting the 14 days of the corpus luteum, and instead of that, on 19th or 21st day, she getting her next cycle. Here, Shadaviryadi Gruda was given internally for Snehana, Snehabana, and after that Virejana was done. Kshiravasti and Uttarabasti is also performed. Then after that procedure, in small quantities of Shadaviryadi Gruda. Here Shadaviryadi Gruda, Shadaviryadi Kshirapaga, Chirabala 101, all these drugs have a capacity to extend that cycle and to lengthen the cycle to get a progesteronic effect. And then another case, primary infertility, she's having complaint of pain after ovulation. After the ovulation, she's having no problem. And from just after ovulation on 5th or 6th day, from that day, I told that the exact time of implantation, she will start some severe lower abdominal pain will start, and her internal medicines just I continued like Phalasarpi, Dadimadi, etc. for but actually it didn't work in that patient. She told that after taking that Chirabala 101 drops mixed with milk, that pain is also get relieved. Actually, that again continued for 1 to 2 months, and with that internal medicines itself, that patient got conceived. And here also, we have to expect that luteal phase defect. So this is the second concern. Then next, the third topic we are moving to, ovarian cyst. There may be cyst, may be fluid filled, complex cyst, endometriotic cyst, chocolate cyst, etc. may be there. So we have to evaluate CA125, CA19, or CEA test just to rule out is there any tumor marker or carcinogenic things are to be elevated. But actually, we know CA125 is not much relevant because any cases of endometriosis or any type of uterine pathology that may be get increased. But even though how much it is, the prognosis of the treatment, we can assess the prognosis of the treatment also. Actually, if the CA125 is to be increased and after the treatment procedures, is it in a right way is going? Like that, we have to do the assessment of the CA125. If it is in a large amount, or surely we have to refer if it is any needed further investigations or further biopsy like investigations. And then Doppler USG to assess the cyst, ascites or blood flow, CT scan, annexal mass, any calcifications, MRI, is it benign or malignant, then CA markers, serum markers, tumor markers, laparotomy or laparoscopy, and for cytology. So these are the investigations needed. Actually, combined with our topic female infertility, actually no direct relation to infertility. But in some cases, they have progressively increasing congestive dysmenorrhea may be present in ovarian cyst like or secondary dysmenorrhea. But actually, in a simple or benign cyst, irrespective of that, if she have any endometriosis or adenomyosis, surely it will affect fertility. We know that there is a simple cyst, it will not affect fertility. Otherwise, the follicles are not developing. But in cases of endometriosis, we know that it's very difficult to manage it if they are grade 3 or grade 4 to that extent, and especially if they have additions. And more than that, if they have due to the endometriosis and additions itself, the position of the ovaries and position of the fallopian tube and everything may be changed. So that here in such cases, the normal conception is very, very difficult. Because even though if we are doing these Shodhana procedures, Panchakarma, Uttarabasti, everything if we are doing practiced, but I think that the additions cannot be, we can't cut that additions by our treatment. And after that, if the position of the ovary, means fallopian tube is changed and some kissing ovaries may be there, we can see that this ovaries have to be very close to the uterus, and if fallopian, if any time the ovulation may happen, but the ovum cannot, the febrile end of the fallopian tube cannot pick the ovum. So, and in such cases, we know that normal conception is very difficult. And so, in such cases, after preparing the kshetra properly, that's Ritu Kshetra, Ambu Bijanam Samagra Dagruyada. So, getting a good progeny, this Ritu Kshetra, Ambu, everything should be okay. So, after correction of the kshetra through our management, like endometrium, through the Panchakarma treatment, after that, we can suggest them for any ICSI procedures or IVF. Now, for get ready, that patient is also one good thing. And then in cases of this simple cyst, here the internal medicines, which should have Lekhana property, Tikshna, Anulomana, like internal medicines, and procedures like Avagaha Sweda, Lekhana Basti, Uttarabasti, Pichu Dharana maybe have a good role. Just a case of infertility with ovarian cyst. She's having only 4.5 centimeter on USG on 2018. She presented with recurrent lower abdominal pain and congestive dysmenorrhea. Here, actually, this 4.5 centimeter uterine cyst is not a much large size, or actually, it's not much significant. But her clinical presentation is regarding to that, or while comparing to her clinical presentation, it is to be considered. And her endometrial thickness was 8 mm, right annexal cyst, PCOD changes on the left ovary, and here the annexal cyst only the 4.5 to 4 centimeter is noticed. But actually, this clinical presentation of the congestive dysmenorrhea and infertility, that's why we managed start the medicines on July 2nd week with Traindyadi Kashaya and Kanchanara Gugulu was given internally. and Erenda Thaila mixed with the Kalyanakshara. This is the important drug of choice for the management of cyst. It should be have Lekhana and Anulomana is needed. If needed, Pagahara. In some cases, we should have to add Punarnavadi Kashaya or Ardhavillam Kashaya, etc. will help to that even this pelvic congestion, and also they may have some choice chances of these congestion syndrome may be there, Shobha, like inflammatory signs may be there, so that we have to add such medicines. Then on UST after repeat the medicines on the next cycle, and the cyst was only for actually this centimeter for 4 to 4.5 centimeter or below 5 centimeter cyst. If it is a functional cyst, there may be chances of disappear without taking any medicine itself. Now, normally the functional cyst may disappear. But in any type of complexity or vascularity is the chances of size may be increases. Okay. Then on next repeated on the next month, amenorrhea was there. So when during that time we checked, it's found that she was conceived with 7 weeks and 4 days. So during that time we stopped all the Trayandhyadi, Kanchanara Gugulu, Kalyanakshara, everything stopped when the UPT is found positive. And then after that some antenatal care or Garbhani Charya continued parallel to the modern management. Here, this is the after treatment, her scan report, and on coming month, the scan report was, it's found that single intrauterine gestation, 7 weeks and 4 days. So it's another case. Here it's a large and a complex cyst. It's about 8 centimeter, 18 to 5 centimeter size on the left ovary, and 4.5 centimeter on the left, means 8 in the right, and 4 centimeter on the left ovary. So here also started the Trayandhyadi Kashaya, Kanchanara Gugulu, and 1 Charak endoton tablet of the Charak, and Gandharvaranta and Kalyanakshara to be started as the internal medicines. Actually, it's having in complex, the bilateral annexal, well-defined oval cystic lesion with low-level internal echoes, and it's a case of endometriotic cyst. Actually, it was a case of endometriosis. And due to the large size and regarding her primary infertility, I advised to take a second opinion. If needed, we should have to remove that cyst, and after that we have to preparation for the pregnancy. That things we discussed with that patient. But actually, after taking 2 months of internal medicines, and we discussed to refer that patient and to do the cystectomy. During that period, that patient got conceived. Actually, due to the on her first scan, this 8 centimeter cyst that was reduced to 6 centimeter, and there is the single live intrauterine gestation with 7 weeks and 2 days. We can see in that scan report. Crown rump length is about 1.16. Then actually after conception, is continued with the Nayopaya Kashaya. Nayopaya Kashaya, out of that, Bala, Jeeraga and Nagara. Small quantity of Bala, less quantity of Jeera and Nagara to be added, and Mahadhanandara Gudiga was to be internally. In small quantities of Phalasarpi to be continued. Actually, after the her next scan report, again the modern means parallel to the antenatal modern treatment was to be right folic acid, and everything was continued. Parallel to that, our Ayurveda medicines were also was given. But during the next scan, just I mentioned that please note the size of the cyst, if it is present, is it increased or decreased? But surprisingly, it is found that both ovaries are normal, no evidence of cyst or mass lesion. Actually, I think that it may be an endometriotic cyst, and we know that endometriosis, the treatment of endometriosis itself is the amenorrhea. So during the pregnancy stage, the effect of pregnancy and maybe effect of our internal medicines, that cyst is to be completely dissolved in that patient, and her pregnancy continued uneventfully and delivered a healthy baby. Here also it is happening on 2019, and she again came for her second baby. During that time noticed, then also there is a 4 centimeter cyst was present. Again we started the medicines like the Hyndayadi and these medicines for the cystic pattern. Here also surprisingly she conceived with internal medicines itself her second pregnancy, and that also say delivered without antenatal period was uneventful. So this is regarding some cases to ovarian cyst, some cases of endometriotic cyst, and some benign cyst have to be discussed here. The next topic is the luteinized unruptured follicle. Here, when we are doing the follicular study, especially if on the 13th day, 14th day, we know that the follicle will reach to an around 19 to 20 millimeter. Then after, if we are repeating after 2 days, it may ruptured. That is the normal pattern. But in cases of luteinized unruptured follicle, what's happening? Here, the follicular cyst or hemorrhagic cyst is happening and there is no ovulation. So what's the management here? Here, the induced ovulation may be the one of reason for the follicle is not rupturing. And in some cases of endometriosis also, the follicle is not rupturing. In some cases of PCOS, if the thickness is to be increased and due to that thickness, the follicle is not coming out. So these are the reasons for the luteinized unruptured follicle. So some medicine choices are the if the follicle is to be increased to 19 to 20 millimeter, just we have to give Jeeragarishta, Lakshmanarishta or Hingojadi, Pulilehya, some Tekshna medicines if you are giving 3 days during the follicle or follicle to large, some cases are observed that it will be get rupturing properly. In modern management, they are giving HCG injection. That is also found to be good in some cases. But even though the cases, if they have more follicle growth like 24 millimeter or 25 millimeter, even beta HCG in some cases that will not work. So in such cases, on coming cycle, if the follicle around 19 to 20 millimeter itself, during that time itself, we have to give our Tikshna medicines to rupture and then monitor again after 3 days. Then we can see that the follicle may get ruptured. It's a case of lady, she's having 31 years, married life 6 years. She's also working as a nursing staff at a modern hospital. As diagnosed as the case of luteinized unruptured follicle. She's taking a thyroid medicine in small doses. All other parameters are normal. HSG, AMH, prolactin, everything was found to be normal. Just I put her follicular study here. On 22nd day, actually on 12th day itself, she got a good follicle, around 20 millimeter. Endometrium is good thickness, about 10 mm. But on 22nd day, just repeated again, if it is ruptured or not, it is observed that it's a hemorrhagic follicle and not ruptured. In that case, on just leave with that medicine, she didn't conceive that cycle. Again, on the next cycle, started with the second day onwards, small quantities of Sukumara Grada to get good endometrium and follicle. Kumarya Sava and Bringaraja Sava, some patent drugs like Elos compound. On 14, 15, 16th day, Hingojadi Churna or Hingojadi tap 3 times before food and Lakshmana Arishta 3 times after food was given. She filled her ovulation and after post-ovulation, some medicines help for the implantation like Palasapi, some medicines are given. Actually, in that cycle, that patient got conceived. So here we can see that the follicle development is to be, in some cases, if the follicle is not ruptured, that may changes as a functional cyst. So the ovulation is not happening there, but due to the endometrium is proper and endometrial thickness is there, so the periods may be regular, even though the anovulatory cycles are to be appeared here. The follicle is not rupturing, but endometrium is okay. So then the next period is to be coming as a normal. In another case, I observed that so the follicle is not rupturing, and at the size of 19 to 20 mm, I have given Pudilehia, that internal medicine, and after that also the patient is ruptured that follicle. But even though after the follicle ruptured, after getting is a good ovulation and endometrium, or other parameters are okay, the patient may chances to get conceived. Here, after conception, her all other things are to be going normal, and she delivered a healthy baby. Then another, this is regarding some ovarian factors which be means closed except PCOS, that is coming later. Then another is the tubal diseases, tubal factors of infertility, infection, pelvic endometriosis, and previous ectopic are the some conditions are to be coming in our clinics. Here we know that after getting proper ovulation, the fimbrial end of the fallopian tube should collect properly the ovum, and through the vaginal orifice or through the external os of the cervix, it should be the semen should be reached here, and the sperm and this ovum should be fertilized. Fertilization is happening at the fallopian tube. Then after fertilization, it should be entering through again through the fallopian tube, and on the endometrium, it will be the formation of the next embryogenesis will start. So any problem to the fallopian tube, it should be starting from the fimbrial end of the fallopian tube, or any blockage of the fallopian tube, or any problem to the ciliary movements of the fallopian tube. It will not capture, and it will not do the proper mobility of the fallopian tube is to be hampered. And then in cases of pelvic endometriosis also happening there, instead of that position, the ovary may be very close to the uterus, and the fallopian tube will be elsewhere. So they can collect to the fimbrial end, and the fertilization is not happening properly. So in tubal block, if they're having some mucus block, in such cases we can do management by intrauterine utterabasti. But actually, if there is any structural problem to the fallopian tube, it cannot be managed by our treatment. But if there is any mucus block, or if there is any previous ectopic pregnancy, we have to prepare the next tube for healthy for the next conception. So for that, we have to do accept a treatment protocol, some Sneha Sweda, and medicines like Brihatyadi Kashaya, Sahajaradi Sevya, or Sahajaradi Daila is also have a good action on the ciliary movement of the fallopian tube. Sukumara Krida and Sukumara Kashaya is also good here. And Avagaha Sweda and Uttravasti is also good to reduce that block. 2 to 3 means 3 repeated cycles of intrauterine Uttravasti may help to means clear the fallopian tube. If they have any mucus, or without having any structural abnormality, we can do have a good prognosis there. Okay, so this is regarding fallopian means tubal factors of infertility. And then uterine factors, here chronic endometritis, endometriosis, uterine fibroid, congenital malformation, hypoplastic uterus, inadequate endometrium, all these are coming under uterine factors of endometriosis. Here main thing happening, even the ovulation is everything okay, but implantation failure is happening in such cases. So one case, infertility associated with reduced endometrial thickness. Actually, she is having primary infertility, married like 4 years. She's very, very lean patient with regular cycles, but oligomenorrhea. It means actually it is diagnosed as the oligomenorrhea and reduced endometrial thickness, or artavakshaya. On her scan report, it is found that the endometrial thickness is only 5.4, and after ovulation, it's about only 5.7. We know for getting a good endometrium for proper implantation, it's about 10 to 11 mm. After more than 9 millimeter is good endometrial thickness to get a proper implantation. Here only 5.7. So it's very lean patient. Agni Deepti was given, then Dhatu Pushti, some medicines like Drakshadi Kashaya, Kumarya Sava, Draksha Rishta, and for getting Brahmana, Dadimadi Gruda in small quantity. So actually after this internal medicines for Dhatu Pushtigara, the endometrial thickness is to be increased to 7.8 mm. But even though in that case she didn't conceive, again started with her all other factors. AMH was normal 2.4, dominant follicles had to be developing, but the endometrium was very thin. Here, in small quantities of Sukumara Grida, Drakshadi Kashaya was given, Kumari Asava and Prangarajasava were also given. Actually, in that cycle, she got conceived, and that is also have a healthy baby. Then cases like congenital malformation. Here the uterine segmental anomaly or bilateral PCOS. Here we can see that just this is a case when I doing the examination on the per speculum examination. At first time, one cervix is to be coming out, and as a sudden. From the side of the one cervix, another cervix is also to be coming outside. So just after that, after the examination, I checked her USG report. It was found that it is a type of uterine segmental anomaly, and she is having double cornus. That's right cornus and left cornus. Both the cornus or both the uterine segment having good size, and here the conception is possible, but chances of abortion is more in such cases of the segmental anomaly. And then hypoplastic uterus. Here the hypoplastic uterus, sometimes it is very, very difficult to manage. The prognosis is very bad. Here the size of the uterus about 4.2 to 2 centimeter, endometrium 6 millimeter, and right ovary and left ovary meshes very small. She's having primary infertility, only induced cycles, and or while doing the hormonal assay, her AMH value less than 0.01, and FSH values to be like a menopausal value. Even though she's having young age, that's around 30 years of age, her FSH value is to be found 61.8. So here also it's very difficult to manage, but we can accept the protocol I explained on the, even though if it is uterine uterine anomaly or hypoplastic uterus, but also we can do the treatment protocol like that. Then uterine fibroid. Actually, uterine fibroid, we know 3 types. That is the pedungulated subserous uterine fibroid, which coming to outside the uterus, and that is the subserosal uterus. Then within the wall of the uterus, that is the intramural fibroid, and within the uterus, that is the submucous fibroid. So these are the 3 different types of uterine fibroids. Here, related to infertility, if we are talking about submucous fibroid inside the uterus or intramural fibroid within the wall of uterus, there may be chances of implantation failure may happen. Because if the fibroid is to be sitting near to the point of implantation, or after fertilization, they are this coming to the uterine, and when they are coming to implant at that place, this pelvic congestion and also some intramural fibroid is sitting there, it's difficult to implant, and the implantation failure may happen. So that I remember one case, she's working as a bank employee. She's only about 4 centimeter intramural fibroid was there. Actually, 4 centimeter intramural fibroid is not a problem regarding to fertility. And just I treated some internal medicines, and also just as a Virajana and Vasti was given. But actually, after taking that internal medicine, she got conceived. When the morning the UPT is found positive, at the night itself, she started heavy bleeding and heavy and painful bleeding. So it's found that it started to implant, but the intramural fibroid may hinder that implantation, and that may end up with an abortion, or means a miscarriage of the to that patient. Again, we prepare that patient by Snehana, by using Gugula Tiktaka Kradavas internally given to that patient for Snehavana. Then Virajana, again Vasti to be continued. Then next time she conceived, and that was an uneventful pregnancy without any abortion. She got a healthy baby. Here also, but actually, if the means fibroid size is 4 centimeter or 4.5 centimeter or less than 5 centimeter, we are not giving much importance for the fertility. But if you have to think about, is there any problem to the implantation? This another case, she's having married life 10 years, primary infertility, TICE ICSI procedures, 6 times IUI was done. on her checking about all her previous history, there was the some myomectomy was to be done. Small fibroids was there, myomectomy was done. And when dysmenorrhea and low back pain was her clinical presentation when come to OP, and some internal medicines like Saptasara Kashaya, Hingojadi was started. Then to get good follicle, Tilam and Shakara was given. But considering her chronicity of the disease, I started the Panchakarma therapy, Rukshana by Vaishwanara Churna, Snehana with the Sukumara Krita and the Mahanarayan Taila, Swedanam, Videjanam, all the things are to be carried out, like Navasti and Uttravasti done. After doing, we are waiting for the second, means 2 months repeated the Leganabasti and Uttravasti. By considering the chronicity of the disease, we can do 3 cycles of the repeated cycles we can do if possible. In that case, we are waiting for the 3rd cycle, but actually that patient didn't get her menstruation, and when we checked her UPT, it was found positive. So after Shodhana therapy itself, she got a say good conception. So here we can see that even though after 10 years of married life, after ICSI treatments had to be failed. So here one thing I did forget to mention, that the male partner simultaneously, the male partner is also undergone this Shodhana therapy, parallel to the, similar to the female patient. Then another case of simple endometrioma. Here the endometrioma is actually it's a small size but having a complex nature is to be presented for that endometrioma. As considering her endometriosis or endometriotic pattern, just I started here also this Traindyadika Shaya, Kanchanara Gugulu, Gandharveranda mixed with the Kalyanakshara was given internally. And then after every month, I advised her to take Videjana by taking Gandharva Eranda. Here also, actually, she went these medicines with abroad, and after taking these medicines and Videjana every month, after 3 months of the internal medicines, she got conceived, and that was a healthy conception. Then another case is the chocolate cyst, primary infertility 6 years, bilateral chocolate cyst. Here, Saptasara Kashaya Yogaraja Gugulu was given internally. Varanadi Gruda selected for the Snehana, and the Leganavasti, Uttravasti, etc. The procedures had to be given. Here also, after noticing the follicular study, sonologist advised that some follicles may develop, but due to the presence of chocolates, it is not completely or correctly visualized. But she's having some symptoms of ovulation is to be noticed, and after the treatment, we advised her to do the proper intercourse during the ovulatory phase. During in between that treatment or during that treatment phase itself, she got conceived. So this is regarding some uterine factors of infertility. Then coming to cervical factors. Actually, in post-coital test or sperm cervical mucus contact test or anti-sperm antibody are the test to detect or investigation for the cervical factors. And in vaginal factors, some septate vagina, narrow introit tests, like some pathology may happen. Or other things very commonly in our OPD, which is the abnormal discharges, vaginal factors, which is having abnormal vaginal discharges, which also contribute to one factor of the female infertility, because due to the infectious condition of the vagina or cervix, that may also causes for the may have some chances of getting primary infertility. In such cases, what we can do the management. Some local treatment like yoni kshalana, the management of the yoni srava, Slaishmiki yoni vyapat, Paitiki yoni vyapat, and Paripluda. Paripluda is having the yoni vyapat, which is having pitta predominant, and also here the dyspareunia may be. Gramya dharma rujabrisham is the one of the important concern of the Paripluda yoni vyapat. On examination, we can, on speculum examination, it may see that there is cervicitis or infectious conditions may have. So by analyzing the dosha predominance in Kapha predominant conditions, yoni vyabats like Slaishmiki, Vipluta or Upapluta, symptoms like Kandu, Shweda, Pichilasrava, Alpavedana and Shaitya. So the medicines choices of Kshalana, which is having Tribala, Nimbapatra, Dhanyamla, Areghuda, etc. The modern diseases like candidiasis, trichomonas vaginalis, etc. have the symptoms of Kapha predominant yoni vyapat. And here the internal medicines like Mirgundyadi, Areghadadi, if some choices like this, Tribala Gugulu or Mignavadi, Chandraprabha, there are so many choices we have medicine, but the analysis of the case or dosha predominance we have to analyze is to be an important concern. Here we have to do the case taking or history taking, and along with it's better to do the pelvic examination. So better to do the per speculum examination itself. Then alone we have to visualize the vagina, cervix, and if there is any infection, the nature of discharge or color of discharge, if there is any cervicitis like that. Then in Pitta predominance conditions, the yoni vyapat like Paitigi, Paripluta or Mamini, symptoms like Daha Paga Pudi Ganda, Ushna, Kunaba, Nila Pita Asidartava, Sroni Vankshana, Ruktoda, Jora, etc. are the Pitta predominant symptoms. PID, pelvic inflammatory disease, is the similar conditions. Medicines like Nalpamara, Panchavalkala, Guduchadi, etc. choice of the medicines for yonic Shalana. And internal medicines like Musligadradi Gashaya, Guduchadi Gashaya, Tiktagan Gashaya are the choices. Here also Chandraprabhavadi. And then if have the patients having the chronic cervicitis, then we can add Gugula Tiktagagrada, Kadali Matusnuhi Rasayana, etc. to getting the means good cervix also. It's a case of vulvovaginitis, married since 2 years. She is having presented with itching and abnormal discharge. She want to conceive, anxious to conceive. Some internal medicines like Arekudadi Kashaya, Chandraprabha Vadi was given internally. Yonic Shalana by using Tribala Kashaya, and after that Dadimadigrada given internally. And after the correction of the acute infection, Dadimadigrada given internally, and after means correction of the infection itself, she got conceived. Then another case, vulvovaginal infection. Age of the patient, 23. Married life 3 years. And then she is having her LMP 19/11/2020. Then regular cycles. She is having on examination vulvovaginal infection, and the case diagnosed as the Slashmiki Yoni Vyabata. Here the internal medicines are Mirgundyadi Kashaya and Tribala Gugulu was given. And again, some medicines like Leucorid to reduce that means infection. Chalana, Yonic Chalana, Kalkadarana, Piju was also carried out. Chalana by Arekhuda Kashaya and tongue mixed with the Tangana, the Yonic Chalana was done. And after that, Piju Dharana with Jatya Degrada. Here also after correction of the acute, this is the before treatment, her appearance of the cervix and discharge was there. Then after treatment, here also after correction of the her infection, that patient got conceived. So after conception, Mahadanandaravadi, Chadavariyadi Gruda, Guduchadi Panaga was continued on her first trimester. Then here also it was a healthy pregnancy. Then another case with cervicitis. Cervicitis here, primary infertility, married life 2 years. On examination here also white discharges, abnormal discharge was there, and some cervicitis on upper and lower lip of the cervix to be found. Some cervical erosions. Here Shara was to be performed. Here the before treatment, just after the before Shara treatment and just after the Shara treatment. On her face also there is so many changes on the pimples and acne was there, but after conception that was also reduced. Here the treatment carried out like that. She's having cervicitis. Yonic Shalana was done and Kshara Karma. While doing the Kshara procedure, we can select Tutta, copper sulfate or Tutta for Kshara Karma, or Tangana. Can be the powdered Tangana can be placed on the sponge holding forceps with the use of a cotton swab and can be placed on the affected area, or otherwise Tutta can be placed on the affected area. Then Chalana, again Piju. So the procedure, if we are doing the sponge holding forceps, just holding the copper sulfate or just wash the copper sulfate by using any triphala kashaya or Dettol solution and just touch that means tutta on the affected area. After again, simultaneously after putting the tutta, just wash the affected area by using Parampara Ayurveda and just completely clean or wipe out the area. Just after the Shara procedure, it will be like that. The epithelial cells become the changes. We can see as on a sudden we can see the changes. And after that, after Shara Karma, to getting more Rukshana, to avoid that Rukshana, some Grida, Tiktaga Grida or Gugulu Tiktaga Grida can be applied or can be filled by using syringe, 10 ml syringe. So this is the normal procedure we are doing for the Chara Karma. So here in that patient, she conceived after 2 to 3 months of the treatment and internal medicine. Here she is having Arakhodarishta and Crimicnavir is also given in that patient. So after the treatment procedures and the internal medicine itself, she got conceived. Then again, coming to the one another case is the anti-sperm antibody. Here the age of the patient 34 years. Else she's having one child 10 years. Presented with secondary infertility. On obstetrical history G5, P2, L1 and A3. That's 5 times she conceived, 3 times aborted and 1 baby now, live baby present. Here she presented as the, she's having some anti-sperm antibody positive, but on examination, she's having yellowish vaginal discharge, increased body heat was there, and on per speculum examination, cervix found to be eroded. Here the case on USG report, it was PCOD was there, but actually coming to her clinical history and examination, she is having Pitta Vardaka and Pitta Vada, dosha Pitta plus and Vada plus. That was her doshic involvement. Here the internal medicines like Kudu, Chadi Kashaya, Chandraprabha Vadi was given internally. Then on first cycle, Triphala Kashaya was used for the douche, and on coming cycle, Nalpamara Kashaya was selected for that. Then a secondary infertility considering Snehabana was done by using Dadimadi Gruda. And again, Leganavasti is also carried out considering PCOD. Here, all the mainly focused on the Pitta Pradhana or Pitta Shamana treatment was given to that patient. Actually, after 3 months of the treatment, that patient got conceived. Here we can see that whether she is having any PCOD or anti-sperm antibody, but we have to analyze the dosha predominance of the patient, and according to that dosha predominance, we have to do the examination if possible, per speculum examination, and do the treatment, any local treatment or Panchakarma Shodhana treatment or Sthanika Chikitsa according to the dosha predominance. That will help whether it is PCOD or whether it is anti-sperm antibody. That's the lesson we have to take, or that's the message we have to carry over in our fertility management. So then coming to the last topic, the PCOD, I think if you have sufficient energy to listen, then I will continue. If needed to stop and discussion, we can stop. Otherwise, I have to continue about 20 minutes more. Dr. Rahul, let me continue.
Yes, ma'am.
Okay. Then if any discussion needed, if the time limit is over, then we can continue on the one group is created by Dr. Rahul. If it is possible, we can do like that. Or if time is enough now, we can discuss.
No, madam, continue.
Okay, thank you. So it's a very important topic, and in our common OPD, as a lifestyle disorder like sugar, cholesterol, diabetes, and everything, the PCOD is very, very, very common. From the adolescent age itself, not in adolescent, if you are checking any weight gain or any some cosmetic issues, some patients are to become, some small girls are coming in with 9 years or 10 years with her some acne or otherwise acanthosis and skin color changes and hair fall, etc. Then if you are checking that in some small children also have some changes of PCOS pattern. So surely we know that we have to know how to approach the PCOS. As per Ayurveda, it's about Nashtartava, Grandhyartava, or Pushpatni. In OPDs, the manifestation may be like menstrual abnormalities, delayed menstruation, maybe in heavy. When in one OP, if there is 10 patients or 5 patients are coming with means PCO, we know that 5, of course, 5 different patterns of PCO. Some patients may have amenorrhea. Some patients have heavy bleeding. It cannot be stopped by medicine. Then, according to the body pattern, some may be very obesity. In some way, very, very lean patient. So different type of presentations like means obese may be there, lean PCO, moderate PCO. They may present with cosmetic issues like acanthosis, hirsutism. So these are the main concern of the PCOD now. And coming to their reasons of or nidana we are to be analyzed, it may be sahaja or bija dosha, aharaja nidana or viharaja nidana. Then coming to aharaja, we know most of them are needed to the junk food and also spicy food, junk food, and then abhishanti type of food. Everything very, very commonly we are using now. And the biological clock is completely altered. The sleep pattern and the stress factors is very, very more. Even related to study or job related or family related, everything concerned, most of them have to be worried and stressed out due to their family or work or in studies. So that these all factors may contribute to the manifestation. Of course, we know PCOD is not related to the ovary. It's a PCOS, polycystic ovarian syndrome. It's completely manifest on our whole body. So the aharaja nidana, which is having adeshana, vishamashana, vidahyashana, adimadura, snigdahara, abhishanti, and sandarpana vyadi. Then coming to Viharaja, it's Avyayama, Divasopna, and Ratri Jagarana. Actually, due to the means work pattern, work-related issues, some patients or some children, they don't know not enough time to take their sleep also. So this altered biological clock itself is a reason for the this Viharaja pattern of this PCOS. So the complete manifestation of the Jadaharani, if we are taking, Kashyapacharya described that Pushpatni. That is a complete, is a picture in our mind, there is a picture of PCO, it may be like Pushpatni. Vrida Pushpam tu yanari, yata kalam prabhishyadi, stula lomasha gandava, Pushpatni satu revati. Here the Pushpam is not coming out, this ovulation is not coming out. There may be lomasha, means masculine pattern of hair, it may be present on our lower chin or in abdomen position like that. And this obesity is also there. But it's the major part, but we have to think about the lean PCOD also. Then coming to the diagnosis or the Rotterdam criteria of diagnosis, excuse me. Any two of the 3 must be present, oligo or anovulation, clinical and or biochemical features of hyperandrogenism, polycystic ovaries or imaging. Usually when the patients are to be coming with this USG report and PCO pattern or PCO, then we can't to reach a complete diagnosis of the PCOS. Instead of that, according to the ovulation or the hyperandrogenism, and out of the 3, 2 must be present to diagnose the PCOS. We know in normal physiology of ovulation, the follicles are developing on 14th day or 15th day to reach a Graafian follicle, and that may rupture and the ovum will come out. That's the normal physiology of ovulation. Here the hypothalamo-pituitary ovarian axis, it will be coordinated action. Therefore, the chandelage will be coming. Then the follicle development is there. Ovulation is okay. Development of corpus luteum. Then the production of estrogen and progesterone. So this is the normal coordinated action of the HPO axis. But what is happening in cases of this PCOS? This coordinated action is to be lost. This pulsatile and harmonic nature is to be lost, and the GnRH is to be upset. And during that time, the FSH and LH is to be not producing properly. The follicle development is not there. There may be no ovulation or delayed ovulation. So there is no menstruation or delayed menstruation. That is to be happening in such cases. So what are the investigations we have to do? There may be altered FSH and LH ratio, increased androgen levels, increased prolactin level may be there, and the insulin should be, we have to check out, and then sonology, the number of the follicles and like that. So what will be the treatment approach of ours? Here the Nashtartava or Nashtapushpa, Doshe Avrita Margatwad Artavan Nashyadi Striya, Vata Kapavrita Margana to Apravartamana. Here Dosharodha, Vada Kabarodha and obstruction of Srodhas is to be happening here. And coming to the Samprapti Gadaga, here also the manifestation will be in the form of Nashtartava or amenorrhea or oligomenorrhea one side. There is the Dosha Pragoba will be Vada Kabarodha and Artavarodha. But another side we have to think about this heavy bleeding like DUB presentation, and in that case we have to consider Pitta Anubandha and the Pitta Dosha. So if there is in the clinical report or in the USG report, if there is PCOS, but we can't give a protocol for the same treatment, even though if it is having heavy bleeding or Pitta predominance, or if it is having amenorrhea or Kapavada predominance. So that according to dosha predominance also we have to think about. Then coming to Samprapti Gadaga, mostly it is having Kapavada. In some cases, it may have Pitta Anubandha. Dushya, Rasa, Rekta, Mamsa and Meda. Agni, here Dhatvatni Mandya. Here what's happening from Rasa to Rekta, Mamsa, Meda, the complete Dhatu Agni should not be proper here. That will be starting from Jadratni Mandya and that may end with Dhatvatni Mandya, and that's why the proper channeling is not there. Then Udbhavasthana, Amapakvashaya, Vekta, Garbhashya and Sarvasharira, Srodhas like Rasa, Rekta, Mamsa, Meda, Dushti in the form of Sangha, Adipravarti or Grandhi. Rogamarga will be Abhindra. So this is the presentation, maybe Nashtartava, secondary amenorrhea, oligomenorrhea or hypermenorrhea, which is having Kabavada Avrana and Pittakshaya. On other hand, it will be Amidartava, and here we can consider Pitta Vriddhi. So tatra samshodhananam agneyanam cha drivyanam vidhivat upayogaha pittalai upachare tat pravartamanam in case of vada kabadushti and pittakshaya. But if there is more pitta vriddhi, then pitta shamana treatment should be adopted here. So vata kapashamana, kapameta chetakara, srodho shotaka, agnidipaka and pitta vartaka in amenorrhea. And if there is amenorrhea, we should give the medicines like Saptasara or any Abhyarishta, Pulilehya, Rajapravartini Vadi. And if it is responding, we can assess that the endometrium is there. It's a good endometrium like 6.5 to 7 millimeter endometrium to initiate a good menstrual flow. But if it is not responding, during that time, if you are giving some medicines, the periods, maybe 2 months or 3 months amenorrhea, the patient is coming to us, we are giving some Rajapravartini Vadi or Abhyarishta or Saptasara Kashaya. Within 1 week, periods is to be started or menstruation initiated. We are happy and patient is also happy. But what is the next step? We are blindly continuing that same medicine to that patient. But actually, it's not that. Here, if the patient is having to get a good endometrium, or if we are giving that medicine, if the patient is not responded or the menstruation is not initiated, we have to think about the endometrium is not sufficient to initiate a menstruation. So again, after getting proper Agni Dipana, for Agni Dipana, we can give again Saptasara, Ashtachurna, Hindu, Jadi, Vaishwanara, everything. If it is not responding or if the menstruation is not initiated, then we have to give small quantities of Sukumara Grada, Datimadi Grada. If the patient is having stress, then Kalyanaga Grada, or otherwise like Tailas, Tila Taila. These medicines we have to give internally in small quantities in empty stomach to stimulate HPO axis or to get a good endometrium and a good follicle. Okay, I think that point is clear. Then in cases of adolescent and multiparous, what's happening? They want to regulate their menstruation. For that, from second day or third day of menstruation, we are giving these less quantities of Sukumara Grida, Dadimati Grida, or Kumarya Sava, Draksharishta, Brinkaraja Sava, Tila, Shadaguppa. These are some choices of medicine now. All of medicines we have, according to the patient, we have to select 2 or 3 medicine. Okay. Then after getting a good endometrium and follicle, after 2 weeks or 3 weeks, we have to give some Artava Janaga medicine like our Anulomana medicines like Saptasara, Chirivilwadi, Amrutotara, Bayarishta, Kanashadahwadi, Rajapravartini Vadi. So this is the difference. Okay. Then this is in case of adolescent and multiparous. Then another case is the infertility associated PCO. From second day, the same medicine like Dadamadi, Kumarasava, Draksharishta, these are the same Lakshmanarishta, etc. But after getting ovulation, we have to give, instead of that Tichna medicine, some Garbhasthabana medicine like Phalasarpi, Lakshmana Mula, Chirabala, Shadavarya, etc. So this is the difference to deal the PCOD patients if they have adolescent age group, multiparous or infertility. Then to get a good follicle is very concerned here, especially if they are taking continuously the progesterone pills or hormone pills. It's having ready to, it's not, in such cases, we have to do some Shodhana treatment itself because within this endometrium and that pattern is will not work in some cases if they have after taking the hormone tablets, the ovary is inactive during that time. The endometrium is okay, but ovary is not much active. So we needed to stimulate that ovary by using this Tila or Shadaguppa like that and some in our treatment methods or Panchakarma treatment to get a good follicle. Because not endometrium is enough to, by using the progesterone or mepride pills, we have to create an endometrium and also to regulate the menstruation. But actually, it is not possible in fertility cases. We have to give a good follicles also. For that, to stimulate the ovary, that is also needed. Then here also we have to do Shodhana and Shamana treatment. So according to the chronicity of the disease and BMI, we can do. There are so many drugs for Shodhana, Shamana treatment like Saptasara, Vatakapa Shamana, Pittavardaka, Srodoshodaga is indicated in Kritsartava, pelvic pain and additions. There are so many Anubanas are to be described like Gula, Kana, Padu, Hingu and Grida. Ingredients are the Punanava, Villa, Kulatta, Erendamula, Sahajara, Shundi, and Agnimanda. Some indications like Vata Kabashamana, Vidbanda, Agnimandya, Yoni, Hrit, Kukshi, Prishta, Shroni, Shuleshu, Sadhya Shamedi. Means the pain should be relieved as on a sudden by taking Saptasara Kashaya is indicated as the therapeutic indications. In practically, we can take in endometriosis, PCOD, dysmenorrhea, constipation, piles. So according to Anubana, we can add gula, kana, hingu, fried hingu can be added. Or instead of that, hingu ajadi, churna or hingu ajadi we can add. Then some medicines like hingu triguna daila, hingu tritaila is to be, or grida is added. So kumara grida we can add, or any plain grida we can add. Or otherwise thailas like pipalyadi anavasana daila, or as an anubana, hingu triguna daila to reduce that additions and like. So according to our yukti, we can add different medicines as anubana, as a single drugs or in preparations. Then Chirivilluadi, we know, Kavata Kabashamana is Bagandara, Gulma. These are the indications and hypothyroidism, PCO, uterine fibroids, etc. we can use. Gandharva Hastadi, Gandharva Hasta Chirivilla Chitraga, this Punarnava, all the means ingredients. Here also dysmenorrhea, retrograde ejaculation, indigestion, Pakwashya Vadakoba, Kadigraha, Rudrasi are the main indications of the means Gandharvasta. So these are the Lomana drugs we can use for the to initiate the menstruation. Then another group is the Tila, Chitraga Grandhigadi, Kanashadahadi are more Tikshna drugs like Kapavada Shamana, Pittavardaga, more Pittavardaga, more Shoto Shodana, Artavajanaka, and PCO is associated with the amenorrhea as the indications. But we should have to keep in mind that if the patient is having Pitta predominance, even though in USG report she is having PCOD, but if she is having Pitta improved, then you should not give Kanashadahvadi Kashaya or Saptasara. Because due to that Pitta Vardagata, there is a burning sensation, especially they feel some small pus points on the, even on the vaginal area, some burning sensation will also appear to that patient. So just Tosha should be kept in mind. Kanashadavas is a very good drug to initiate the menstruation, and also in PCOS because Kanashadahu adhikaranchadaru bargi kulate satilehi vipakam tada resonena cha siddham ambaha. Like that, Kanashada, every drugs are, all ingredients are very tikshna. Rasona means garlic is also added in that kashaya. Kapavada Shamana, Pitta Kara, and indicated in amenorrhea. Then Tila. Tila is having good estrogenic effect, good promote ovulation, Nashtartava, Nashta Pushpa, Rekta Gulma, all these conditions it is affected. Tila can be plainly prepared the kashaya, and here also like Gridha, Guda, Vyosha, or we can add Asanubana. So this is the another group of drug. So one group Analomana, then another more Tikshna. Then coming to Pitta Shamana drugs like Guduchadi, Pitta Shamana, which reduces burning sensation. Cases of antisperm antibody, SLE, systemic lupus erythematosus, luteinized means luteal phase defect, thyroid disorders, yonisrava, pradara are the indications. Then Trayandyadi, it's having Kapha Pitta Shamana, Legana, Pagahara. It's indicated in ovarian cyst, endometriosis, and PCOS with heavy bleeding. So many other drugs for Shamana like Nirgundyadi, Amridotara, Pachanamrida, Gandharvastadi, Padoladi. I'm not going in much details, but here also we can do so many tricks for the Shamana therapy and for Shodhana, as we are described also in earlier slides, like that Snehapana. Vamana is also good procedure for the Kapha increased or Kapha predominant PCOS, Virejana, Vasti, and Nasya, etc. Here, the procedure, Lukshana, I'm not going in detail here. According to the obesity of the patient, BMI of the patient, we can do Udvartana and Snehana by Tila or Grida. Tila Taila, Sarshapa Taila, Mahanarayana Taila are the choices of drug for Snehapana. And Pippalya the Anuvasana Taila, if it is indicated in Arsho Prakarana, but we can incorporate it to this PCOS or endometriosis or uterine fibroid for the Pippalya the Anuvasana Taila. So in combination of Sukumaragrida and Pippalya the Anuvasana Taila is very commonly I'm practicing in the management of PCOD. If the patient is more obese, then Pippalya the Anuvasana Taila is to be added more. And if the patient is lean, then the Sukumaragrida is to be added more. Then so many other drugs like Shadavariyadi Grida, in luteal phase defect, Tiktaga Grida, luteal phase defect, and torch infections, the repeated pregnancy loss due to toxoplasma, rubella, cytomegalovirus, and herpes. Then Kalyanaka Grida, less lean PCO, a stress factor is there. Then Vidaryadi Grida, if endometrium is less and the less lean PCO. Varanadi Grida, another choice for hypothyroidism and hyperprolactinemia. So these are here also for Shodhana therapy. If you are selecting Snehabana, according to the investigation and according to the dosha predominance of the patient, we can do so many choices. Then coming to Swedana, if you are practicing Vamana, 1 day of Abhyanga and 1 day of Utkleshana we are doing. Next day Vamana. For Virejana, 3 days of Swedana. It's not normal Panchakarma principles. Then for Vamana, PCOS associated with chronic amenorrhea, Vamana is indicated. Then Virejana, we know for getting Anulomana and Pitta Shamana. Vasti is also very important for the treatment protocol in PCOS, amenorrhea, infertility, and gynecological disorders. Here for the Niruha Vasti, here Legana Vasti, Vaidarana Vasti is also good. In Legana Vasti, for Dravadravya, Sarshaba, Shadapushpa are taken as the Kalka. along with our Erendamula Kashaya, we can add Dhanya Amla or Saptasara Kashaya or Kulatta Kashaya as Lekhana. That is, there's some differences in different permutations and combinations we can use Niruhavasti and Lekhanavasti. Okay. Then as a protocol, we can take as Uttarabasti. So here for PCOS, endometriosis and pelvic adhesions, then Shara Taila, Shadahwadi Taila, Pipalyadi Anivasana Taila, Mahanarayana Taila, Sahajaradi Taila, etc. we can select for Uttarabasti. If Uttarabasti is not much experienced, then we can use just Yonic Shalana, and if there is no infection, to confirm that there is no infection, and Piju Dharana is also possible to every practitioner. It is not much worried about that. Then, so these are the Shodhana treatment for PCOS protocol. Then if we are checking the follicular study on 11, 13 or 15th day to specify the follicular size, endometrial thickness. If you are writing a prescription to sonologist, please do specify the follicle size and endometrium. If there is 20 millimeter around 20 millimeter, it's ready to ovulate. And if it's more than 8 millimeter endometrium, it is ready to get implantation. So to the sonologist, it will be like a letter we have to give. And this is the follicular study report on the day she is having 16 into 13 millimeter is to be received, and on repeated on 18th day that was ruptured, no follicle, and endometrium 13 mm. It's ready to implantation and have a good follicle. So this is the follicular study report they will give to us. Then just some more cases after that we can conclude. Say case of lean PCO. Shodhana treatment is not always mandatory. Some Medhya drugs, it will be help, like Kalyanaka Kashaya, Kalyanaka Gruda, Shankapushpi, Manduga Varni, have a good role to stimulate the hypothalamo-pituitary axis. Here is a case, she is having no follicle, very lean PCO and reduced endometrium. The same medicines, after getting proper Agni Dipti, I have added Kalyanaka Kashaya and Dadimati Gruda internally. So after that, she got a good follicle, is about 18 millimeter and endometrium 8 millimeter. She's having only 2 to 4 millimeter endometrium was received on previous cycles, but after the treatment, she got a good follicle and a good endometrium. Then another case, this is a lead example to lean PCO. Then another example to obese PCO. She is primary infertility, 11 years, age 32, weight 95 kg, married life 11 years, AMH value I mentioned. In PCO cases, AMH value will be high. Here 9.5, LMP 4 months back when coming to OPD. She's having the past 6 years complete on induced cycle while taking the progesterone tablet, then and not her menstruation is to be attaining. So for getting on examination, it was found some abnormal discharge was there, cervicitis was there. And Chirivillwati Kashaya Vaishwandra Churna was given morning to get the proper Dhatukni Diti. Nirgundyadi mixed with Trabala Gugulu was given evening to reduce that her abnormal pattern of cervix. And after the continue the 1 month of internal medicine, and after that procedures Shodhana karmas to be treated. Uddartana was continued as her, considering her obesity. Uddartana continued for 9 days. Takrapana internally mixed with Vaishwanara Churna. Here the Snehapana I started with Sarshapa Taila. Considering her obesity, acanthosis, and more insulinemic nature, Sarshapa Taila was selected because Sarshapa Taila is to be mentioned in the Prameha Prakarana. The patients who have the hyperinsulinemia or diabetes patient with the PCOD, we can is a Sarshapa Taila is a very good choice of medicines for Snehapana. Then Vamana was carried out. After Vamana, within few days, menstruation attained. Then some internal medicines like Saptasara Kashaya, Shadapushpa Churna was given internally. Lekhana Basti and Uttarabasti carried out. Actually, after 3 months of her treatment, internal medicines and treatment, 10 kg weight was reduced from 95 to 85. Then 83, 81, 78, 75, like that her weight reduces, and her LMP after the treatment, she started to attain her menstruation, but it's not in a regular pattern. Within 35 to 40 days, her periods attained. Her LMP was 22/6/2019. After treatment, she got a good follicle and a trilaminar endometrium. We can see that 11.7 millimeter endometrium and 18 into 16 millimeter follicle. There is a good dominant follicle on right ovary. Actually, that was her LMP. In that endometrium, in that follicle, that patient got conceived with LMP 22/6/2019. Severe LBA, vomiting was there on antenatal period. It was very eventful. But along with the modern management, Nayopaya Kashaya, Mahadanandara Gulika, some medicines had to be given added that reduces her back pain. But even though diabetes is also, gestational diabetes is again started. But even though with LSCS, she delivered a healthy baby, 2.65 kg on 2020. Here also, by surprisingly, after she attained, that baby attained 3 years, 3 years of age, she got her next conception, and that is also delivered now. That is also one healthy baby. So here we can see that after getting the proper ovulation and the second conception is to be attained without any treatment. This case is to be published in JAME, International Journal of Ayurveda and Integrative Medicine. It's available in online. Ayurveda Management of Infertility Associated with Polycystic Ovarian Syndrome, a case report. Then another case is the PCOS with hypothyroidism. Only one point I have to mention here. PCOS with hypothyroidism, but the patient is having more increased burning sensation was there. So, Takradara is selected was the important treatment here. After that, Snehana or Shodhana treatment was done. Here also that patient is conceived, and it's also available in online. This published in All India Institute of Ayurveda, Journal of Ayurveda Case Reports. Ayurveda Management of Primary Infertility associated with hyperthyroidism and hyperprolactinemia. Okay, if needed, you just pass through that heading and it will be available. Then some cases like infertility associated with the diabetes, I mentioned Sashobataila is the better option for Snehabana. Here also Takradara is also good to reduce the diabetes, and so all the other treatment protocol, the same I mentioned earlier. Then again, so coming to PCOS, it's a better prognosis. Comparing to all other like endometriosis or tubal factors of infertility, I found PCOS is a very good prognosis. So we can do internal medicines by Shamana therapy, Shamana treatment or Shamana treatment itself enough to get good follicle and good conception or to regulate menstrual cycle. So along with these all things, lifestyle modification is also needed. If we are coming to Shodhana therapy, here the most of the cases I selected the Sukumaragrada and Pippalya and Vasana Thaila. According to the costa of the patient and the BMI of the patient, we have to small changes we can do in that combinations. Here also, 35-year lady married 14 years, the same treatment protocol accepted, and she got a healthy male baby, 2.9 kg on 2021. Now she is trying for the second conception. So to keep the menstrual cycle, Dinacharya, Ruducharya is very, very important. Exercise is important, but over exercise or Vata Koba is not also good to get a good menstruation or regular menstruation. Because I noticed so many athletics when they are doing for athletes, heavy exercise is there, but irregular cycles. So here the Vata Koba is also not good. So for getting a healthy regular menstruation, all the biological clock should be proper for proper sleep, proper exercise, move meaningfully, meaningful exercise or like that, sound sleep without having much stress, and food should have a healthy plate. Now there is a tendency is that like anorexia nervosa, that's the for getting more obese, and even students like adolescent girls are to be skip all type of good nourishment is completely stopped by taking or fasting and like that. It's also not a good habit. For getting good follicle, good endometrium, there is the BMI should be correct. If the BMI should be very decreased, that also causes the cholesterol is good. Cholesterol is needed to get a good follicle development and good hypothalamo pituitary ovarian axis to regulate. So that for all our patients we are coming to or in front of us, especially in adolescent girls, we should have to advise to take healthy food, a healthy plate, proper exercise, proper sleep without having much stress. This is very, very, very important regarding the PCOS. And coming to fertility, of course, we should have to counsel both the male and female patient. Of course, if they, I'm just mentioning all the female factors alone, but parallel, we have to discuss all the male couple and male factors. So both the Bija Shuddhi is to be needed for the would have a Viryavandam Sudam Sudhi, or for getting healthy and a good progeny. So coming to a conclusion is that Ayurvedic management is effective in gynecological disorders and fertility or infertility or subfertility. But according to the patient to patient and condition to condition, it differs. We are always focusing with the modern investigation, modern parameters, it's okay. But of course, we should have to take a proper history of the patient. During that history taking, of course, we have to get some points if the dosha predominance, if there is an increased burning sensation or body heat is there, if there is any abnormal discharge, or if there is any. So even though if there is any unexplained infertility, if we are taking a case or history taking, we should have to get some points from there. Sometimes if there is have any Vada dosha predominance or Pitta dosha or Kapha dosha like that, any catching point we should have to get from the history taking. So Prakriti dosha, Agni, which plays very crucial role. So according to patient and condition to condition, it differs. So judicious blend of Ayurveda medicine and Panchakarma therapy, surely we will get good results in the management of gynecological disorders and also fertility. There may be failures. Surely it will happen, but of that we know even while doing the ICSI treatment, they are only assured that 40% or 35 to 40% success rate. Of course, we can say that after doing this Panchakarma treatment, our Shodhana treatment, our Shamana treatment, and also Sthanika treatment, we will get more results than that of the such a good percentage. Of course, it is sure. So with confidently, we can move with our gynecological, the management of gynecological disorders and also this fertility sector. Thank you. Thank you all.
Thank you. Thank you so much, ma'am, for the enlightening session. Have touched almost all the points. And we have still 118 participants over there. And if you have any doubts.
Hello.
Yes, sir.
Hello.
Yes, sir.
Okay. My voice is coming, Dr. Rahul.
Yes, sir. It is audible.
It is coming.
Yes, yes.
Okay, it was excellent lecture by Dr. Asma B, and I have thoroughly enjoyed it. I think all the participants who were listening, they must have thrilled because she is having full knowledge of the subject, and everything was explained and elaborated very clearly, and the Ayurvedic concept regarding infertility and its treatment has been very well explained. So I think all the participants, they will avail this opportunity. So I am again thankful to all the participants as well as the organizers. Kerala Ayurveda, because, sorry, Kerala Ayurveda, because they have introduced us to such an excellent speaker, Dr. Asma Bhai. Thank you very much. I think question answer are not feasible at this time, we will take it sometime again. And I will request to the Dr. Asma Bai that she will come again and we will have question and answer session sometime. Thank you very much.
Thank you, sir. Dr. Anit, do you have anything to add? Dr. Anit, are you there? Okay, ma'am, we have one question is there. Anyhow, we can take it. Yeah. Is there any specific care to be taken for Sarshabha Thailam Snehapanam? How can we do this in Aroha of Matra?
Yeah, we can take the Sarshabha Taila, we can directly collect from any shop. But after doing Patra Paga, then we have to give administer to the patient. The dose should be when we are adding the Taila or Gruda, normally from 30 ml as a Matra we have to be start. But if you are starting the Sarshabha Taila, the 20 to 25 ml enough on the first day to start the first dose of the medicine. So according to the next day, how is the appetite and all things that we can improve the dose.
Dr. Navgeet Kaur, you can ask the question. You are unmuted.
Hello, ma'am. Thank you, very much, ma'am, for
Yes.
very good lecture.
Thank
Very
you.
informative.
Okay.
Really, ma'am. I want to ask a question, ma'am. Which type of ingredient you use in Lekhan Vasti?
Okay, like Kanvasti, in one slide, I have demonstrated that for Kalka Dravya, Sarshaba and Shatapushpa is to be added as Kalka Dravya. Then for Drava Dravya, Erendamula Kashaya mixed with the Dhanyamla is to be added for the Drava Dravya. And for Taila, Pipalyadi Anavasana Taila, if you want to the correct dosage, if you are present in that group, I will put the.
Okay, ma'am. Thank you, ma'am. And hello.
Yes, doctor.
Yes, ma'am. Ma'am, one question also I want to ask. In tubal blockage, which medicine, ma'am, you advise mostly to the patient?
Intrauterine for intrauterine.
Yes, Uttar Basti. For Uttar Basti. Yes.
Yeah, for Uttar Basti, on first 1 or 2 days, we are added Kshara Taila or Kalyana Kshara mixed with Mahanarayan Taila on first 1 or 2 days. After that, means removing that Kshara, Taila alone we use. That's one choice. Another choice is the Sahajaradi Taila is also good for the ciliary movements of the means fallopian tube. So this is another choice.
Okay. Thank you, ma'am. Thank you so much.
There are a lot of questions are coming, but the time is already late. And
doctor, you just take a screenshot and put in that our group.
Yes, ma'am.
Within 2 days, I will answer. I will answer according to the time. No problem.
Thank you so much, ma'am, for your valuable time. And on behalf of Parampara and Kerala Ayurveda Limited, I extend our heartfelt thanks to you. And we will. In the group, we will discuss the further questions and doubts. And thank you so much. Have a great night. Good night. Thank you.
Thank you. Thank you all the organizers of this Kerala Ayurveda and Team Parampara and all the participants who are listening the classes. Thank you. Thank you all.